Thanks very much, and thanks Maria and all the team for inviting us to speak. Myself and Julie are delighted to be here with you, and it's a great pleasure just to spend some time just talking about a subject that is very dear to the heart of both Julie and I. So what we propose to discuss with you is the topic of honey, maggots and other medical marvels, and the inspiration for the title of this lecture comes from this book by Robert and Michelle Ruth Bernstein. And I suppose I'm sad because I can spend my Saturday evenings maybe reading books like this around wound care, but I also am a very lucky person to have had the opportunity of working in an area of practice that I love and that has given me so much opportunity, and I'm really grateful for that. So what we're going to talk to you about is just to provide some outline for you about the problem of wounds and why we would be interested in it and the significance that wounds have for people who are affected by them. Then to kind of think, well, why would we look back to move forward? Because in essence, we're trying to drive forward the agenda of change, as we heard earlier. But sometimes we need to look back to make sure that we're not forgetting things that are still important today. So that leads then to discussing honey, silver and maggots, and then maybe just to provide you with some top tips about looking after wounds. And then Julie will come forward with her wealth of experience in the clinical practice arena and provide some case studies which, as Maria said, do have some images, but they're meant to provide you with an idea of the story and the importance of the story. So if we could place that in context, that helps us to understand why we're showing these images. So I guess one of the first things is to try to understand what we actually do mean by a wound. And Thomas, back in 1990, in his book, Wound Management and Dressings, was my Bible when I started in wound management. So you have an idea how long I've been working in this area. But he suggests to us that a wound is defined as a break in the skin that results from physical, mechanical, or thermal damage. So really, it could be some sort of trauma that we have experienced. But it also can develop as a result of the presence of an underlying medical or physiological disorder. And one that springs to mind to us might be diabetes and the risk of developing a foot ulcer if you are somebody who suffers with diabetes. So these are just examples. So somebody who might attend the emergency room on a Saturday night having had a fall, has a cut to the head, and okay, it's maybe a simple wound you might think, but if we don't apply good principles of practice in terms of managing this patient, then it can be problematic for that patient into the future, maybe developing infection or problems such as that. And the image on the right is somebody who has developed an ulcer on their foot as a result of having diabetes. And today we're lucky because we have advanced so much forward in terms of managing these types of wounds that there really is good hope for people who suffer with diabetes because we have good strategies in place to manage these wounds. So just thinking about from a European context, and Posnet et al. And his colleagues in 2009 summarised the resource impact of wounds for healthcare providers in Europe. And they suggest to us that the population prevalence of wounds is about 3 to 4 for every 1,000 people. And it's equivalent to about 1.5 to 2 million of the 495 million inhabitants of the EU 27. And the annual incidence then, that's the number of new wounds that occur every year, is about 4 million individuals with wounds. And if you think about the annual incidence of cancers is about 3.9 million, diabetes 2.0 million, and cerebrovascular accident or stroke about 3.9 million. So it suggests to us that wounds are indeed a significant problem in society and worthy of our attention and clearly of interest to all of you, and that's the reason why you are here, to listen to evidence-based practice and wounds also. But in terms then of looking at about the costs of it, it's suggested that about 25 to 50% of acute hospital beds are occupied by patients with wounds. Now, they're not all admitted with this particular wound or for the management of that wound. This wound might arise whilst they're in hospital, or indeed may occur, as a complication of some process that's been going on while they're in hospital. But in terms of looking at the costs, then Gottrup et al. In 2010 suggested to us that the cost of just one problematic wound is about 6,500 to 10,000 per patient. And it actually accounts for about 2 to 4% of European health budgets. So once again, a very significant cost in terms of the budget that's being spent on healthcare, that this is being spent on wound care, about 2 to 4%. But for us who are in practice, we are so focused on the experience of the patient, and every day when we're dealing with patients, it's their experiences that really are important to us to address at that moment in time. And some work by my colleagues Gorecki et al. In the United Kingdom, we're looking at the influences that pressure ulcers or bed sores have on people. And here this patient describes that he's now in a room because he has a bed sore. He must stay in bed and therefore can't socialise like he normally would do. And he says, I haven't seen anybody. I haven't been out of this hospital room in months. My brain is really just dying in here, not having any stimulation. So if you think about it from the point of view of the person who suffers with that problem, it has a really significant impact on their health-related quality of life. And a further quote which really brings home to us the pain that's experienced by people when they have wounds, such as bed sores. And this study by Hopkins et al., and this is one of the quotes from the study they did, where the patient says, when I am sitting in my chair, just like now, then that also hurts. And if I move a little, it hurts even more. So I sit still in the chair, but still it hurts. And you know, probably if you think about it, one way in which you should prevent people from getting bed sores is to encourage them to move. And then therefore this movement is exacerbating the experience for this person. So clearly if we were able to stop that from happening in the beginning, then that would be a really key focus for us. So we heard about changing population demographics, and from a wound care perspective, the reason why it's important is because we know that by the year 2050, it's estimated that older individuals will comprise almost 17% of the global population, compared to 7% in 2003. So I'm going to let you into a little secret. By the year 2050, I'll be 85, hopefully. So I will be one of these people. And so, like you, I will be as interested in terms of what's happening around healthcare and how that might affect me. Because at the end of the day, all patients are us. We are these people. We're not some people that flew down from Mars just to receive healthcare. It's every one of us who are affected by these problems. But the challenge is, and a study in 2013, a report in 2013, suggested to us that in 2011, the number of healthy life years at birth was estimated at 61.8 years for men and 62.2 years for women in the EU 27. So what that means is that getting older, fantastic, but what we want to be is active and healthy in our older age. And if we don't have good preventative strategies like Anthony told us about earlier, then the risk of not being healthy as we get older increases. And the issues around obesity, alcohol abuse and smoking are of particular interest to us in preventing disease into the future. So now we've placed into context, the significance of wounds, we've looked at changing demographics, we've understood the experience that might be for people. And now we're just asking ourselves, well, in terms of treatments, why look back to move forward? And it follows on really well from what Anthony was talking about earlier, because he was talking to us about the importance of evidence and the importance of clinical experience and applying that into practice. But I remember this quote from a history book. My teacher who taught me history in school wrote the books that we studied. And he had a quote in the front of every chapter. And this quote said, "Those who cannot remember the past are condemned to repeat it." And that's probably about all I remember of the history book. But one could argue that he did influence me, because even today I still remember what was said. But the idea is that if we don't know what went before us, then we're likely to make the same mistakes. Or indeed, we might not bring forward therapies that are fundamentally important and useful to us. And of course, we all know about Hippocrates, the father of medicine. And he believed in diagnosis. He believed in treating the body as a whole and not just a series of parts. So it's not just about the fact that you might have an ulcer on your foot or a leg ulcer, on your limb. You are a whole person who brings your whole being to that experience. And what he said was, he stressed the importance of a natural healing process of rest, a good diet, fresh air, and cleanliness. Now that holds true today, doesn't it? And Hippocrates said this all those many years before. And then these three researchers back in 1976 suggested to us, and Anthony emphasised this in his lecture, that while it's natural to look for future research to provide new modalities of therapy, one should not overlook the successes of the past. And so therefore it's important to place into context. We're not like Homer Simpson, who has such a tiny brain that he can't absorb any new information. And every time something new comes in, he has to dump out all the other stuff. For us, really, what we do is we absorb the new information and place it into context with what we already know and how relevant that might be to our lives and where we are today. So that leads us then to looking at honey, silver, and maggots. And so in terms of honey then, we know from the evidence that it stimulates the body's ability to eliminate bacteria. It has a high osmotic pressure, which means that it draws fluid towards it. And in doing so, that aids in protecting the body against infection. Some honeys, but not all honeys, have a high levels of hydrogen peroxide, and that's suggested to stimulate white cell function, which you know is important in terms of fighting bacteria. It's a viscous, supersaturated sugar solution derived from nectar gathered and modified by the honeybee. And we tend to focus on manuka honey, which is derived from this leptospermum tree in New Zealand and Australia. Now, as Anthony suggested to us earlier, that when we go and look at the evidence base, sometimes we find in some of the reviews that they suggest to us that there is not enough evidence to give guidance for use of honey in general. But at the same time, they're not saying to us that honey does not work. And clinically, Julie will be able to demonstrate to you in some of the cases that she provides for you how honey has a very significant role to play for us in wound management. So let's move on to silver then. So we know that the silver dressings that we use, they contain silver atoms that are slowly released as positively charged silver cations. And these positively charged silver ions, they appear to have a very strong antimicrobial effect. They bind to bacterial walls and they cause disruption of the wall and the death of the bacteria. So clearly something that we might be looking for in wound management today. So they bind to the bacterial enzymes and therefore prevent them from performing their function. And they also bind to the bacterial cell DNA. Therefore, they interfere with cell division and replication. So for us then in wound management today, for wounds that are infected, these topical antimicrobials like honey and silver, they are a rational alternative to antibiotics. Now remember, if we have a patient who presents to us with signs of systemic infection that's affecting their body, we always work as a team with the pharmacists, with the medical team, with the microbiologist to make sure that we are making a good plan of care for that patient. And in that instance, the patient is likely to require systemic antibiotics. However, in some of the wounds that Julie will present to you, the problem is local within the wound itself and not systemic within the body. And therefore, these topical antimicrobials like silver and honey are a very important alternative to us than using topical antibiotic therapies. And there is evidence to suggest that the silver has a very good effect in reducing wound size when it's used in patients over a period of time. So to move to maggots then. We know that maggots have been used since ancient times. In fact, Ambrose Paré discussed them back as far as 1557. And there was a surgeon, William Barr, who was involved in World War I. And he was amazed at the work of maggots because some of the soldiers acquired maggots. They weren't, selectively given to them. They acquired them in the battlefields. And he was very impressed by the role of the maggots and how it helped to protect the life of the soldiers. So he brought that concept back to the United States and used that widely within his practice. But unfortunately, the maggots lost favour due to the emergence of antibiotics. In terms of how the larvae function, they secrete enzymes which dissolve the dead tissue within the wound bed. And then they ingest this dead tissue as a source of nutrients. Also, the physical presence of the larvae, or the maggots, increase the exudate, that is the fluid coming out of the wound, and that helps to wash bacteria out of the wound. Also within the gut of the maggot or the larvae, the bacteria are destroyed because there are antibacterial substances contained within the gut. We know also that the secretions from the larvae promote wound healing because they have a crawling action which stimulates the production of new tissue, which is called granulation tissue. It's called granulation tissue because it's granular in appearance, like cobblestones. And this tissue replaces the tissue that has been lost during the wounded process. So this crawling action stimulates the production of that, which is what we are looking for in the wound. So in terms of looking at some top tips then, you need to understand why the wound is there. So knowing why the wound is there is the first step. The next step is really to understand exactly what's happening within the wound. Is there healing going on? Is there not? Do we think that the wound is infected? Do we think it's not? If there are underlying medical problems, such as diabetes or problems with blood supply to the limbs, it's really important that you seek medical advice immediately. You should never be managing these wounds on your own. If we remember back to Hippocrates, he suggested to us that the body heals itself. And therefore, any causative factors have to be eliminated. For example, if you are somebody who has a diabetic foot ulcer and you are wearing your regular shoes that you've always been wearing for the last 20 years, then clearly a causative factor, which is pressure caused by the shoe, will still be present. And therefore, your wound won't heal. So what you need is to seek the advice from your GP, from your diabetic nurse, your practice nurse, and attend the diabetic foot clinic where you will be offered advice about footwear or offloading of this wound. Because once you offload the pressure, then you are offloading the causative factor. It's important that you seek advice to help you choose the right treatment. So there are a variety of different treatments available, and Julie will allude to these in greater detail for you. But because there are a variety, and just as the amount of evidence that Anthony showed us pouring out every day, it can be confusing in terms of selecting the right product. So you need to seek advice to make sure that you're choosing the right product for your wound at the right time. And then it's important that you remember your whole body health. So not to forget nutritional status and making sure that you're taking a sufficient amount of exercise. And remember that from your own health and well-being, that's very, very important, because if we are stressed and not taking care of ourselves, the body produces enzymes which can impede wound healing. So going back to what Hippocrates said about managing yourself as a whole being. Of course, really prevention is the key, because it's so much better than healing, because it saves the labour of being sick. So now I'd like to hand over to my colleague Julie, who will continue the story.
Good evening, everybody. Thank you, Zena. That was really good. And thank you to Professor Cummins as well. Your lecture was very good, or Dr. Cummins. I'm just going to present a couple of case studies now in relation to honey, silver and larvae therapy. I'd just like to say there are low evidence, as Dr. Cummins was saying earlier, I was asked to present some case studies, but I'd just like to mention that we do have some good randomised controlled trials and systematic reviews on the such of honey and silver in the literature. If anybody is interested in reading them, I can back them up with references. So, as Zena said, it's very important to remember that the patient is a whole person and it's not just the hole in the person that we're looking at. So it really is important that we kind of listen to our patients and that we try to understand what is the most important thing for them. So on a week-to-week basis, when I see clients in the clinical placement area, I try to sit down and talk to them about what's the most important thing to them with their wound. So it isn't always about healing. Sometimes it's about the pain, sometimes it's about the odour, sometimes it's about infection. And sometimes it's just about their dignity or, very, very simple things, really. And I'd just like to mention as well that if some of you have come here this evening looking for the magic bullet that's going to cure all your wounds, I'm afraid you better leave because there is no magic bullet. Factors are multi. Every patient is different and every wound is different. So it's really important that we try to look at the best evidence, listen to our patients, make a holistic assessment, involve the whole multidisciplinary team, and then we come up with a plan of care. And when we talk about a plan of care, I would always try on a week-to-week basis as well, come up with one goal that we're trying to achieve in those 7 days. And if we try to, if everybody's reaching for the same goal, we tend to have less people trying lots of different products on the one wound. So you tend to get better results at the end of the day. So just to talk a little bit then about the case studies. As already previously mentioned, Zena talked about the anti-inflammatory effect of honey. We use Medi honey in our patients. It's clinically approved and tested, and it's provided by our pharmacy department. It kills bacteria, we know this in the evidence. It has a high osmolarity, so as Zena said, it diffuses the fluid from maybe a wound that isn't weeping so much to more exudate. And it's important to tell the patients this because sometimes they get really anxious if the wound hasn't been leaking and much fluid, and then suddenly now it's leaking an awful lot and they worry about infection getting worse. It alters the wound pH, as Zena already mentioned, and this is important because very often the patients with complex wounds, the pH may be too high or too low, so it's important to get the pH right so that the oxygen levels to the wound are better. And if you've good oxygen and good nutrients, the wound will heal. It generates hydrogen peroxide at low levels, although I would say Manuka honey doesn't really generate hydrogen peroxide. It's known as the low peroxide honey. So here we have a patient with really, really awful bilateral venous leg ulcers. I'm sorry for the pictures now. But this poor lady had been through multiple treatments before she came to us. The reason for her admission was totally different to her leg ulcers, although she was being treated for a cellulitis, and she did need systemic antibiotics. And Zena already mentioned that sometimes topical treatments on their own don't work. We sometimes need to treat the patient systematically as well. But we would always liaise with the microbiology team. We always culture wounds. We make sure we know what bugs we're dealing with. So this is a 78-year-old lady. She did come in with treatment for cellulitis, but she was also being treated for a chest infection. She did get IV antibiotics. She had a long history of venous leg ulcers, so she had these leg ulcers on and off for years and years. And the poor public health nurses' hearts were broken trying to treat her with compression. But the fact that she's a non-insulin dependent diabetic really does impede our ability to be able to put people into compression because sometimes they have peripheral vascular disease or complications with their vessels due to narrowing of the arteries as they get older, as a lot of you will know. So it's not always an option for us to put them into compression, which would be normally the therapy for venous leg ulcers. She was sensitive to a lot of dressings because over the years she sensitized to them. And she was unable to tolerate silver because she said it stung too much. So that was one antimicrobial that we couldn't use. So really what our aim then was for this lady was to deslough the ulcers, to get rid of some of the dead tissue, to make sure that we could absorb the exudate and protect her surrounding skin, because as you could see they were a little bit white, which meant there was too much exudate going on and we needed to control that. Obviously pain, as Zena said, can be crippling for patients and it can really reduce their quality of life and their ability to be able to go outside of the house, go shopping, have any sort of interaction with other human beings. So reducing the pain is paramount. Reducing the bacterial bioburden in the wound is very important, and protecting the peri-wound skin, because as you well know, wounds heal from the outside in, and important to protect that peri-wound skin so that the epithelialization can occur. And then we wanted to be able to elevate the limbs as much as she could tolerate. So here you can see that she has some granulation, but also some sloughy areas. So here is what we would call sloughy areas. The whiteness is the maceration, and there's some granulation. But with venous leg ulcers, the gravity of the fluid always goes down, so the ulcer tends to spread because the exudate can be quite corrosive to the peri-wound skin. So controlling that exudate is really, really important. We tried honey on this lady, and you can see she has some surrounding erythema as well and cellulitis, and she couldn't tolerate any silver dressings and antimicrobials, and it was very important that we try and monitor the venous return as well. So we used a honey dressing. We were able to control the exudate using an alginate honey dressing. So as Zena said, the honey can come in a tube, in a paste form if you need to put it into a cavity. It can come in an alginate where it's more absorbent. It can come in a tulle dressing if it's a quite superficial wound. But this lady had a lot of exudate, so we were using an alginate form of it. We protected the peri-wound with some barrier cream and emollients, and that's really important. She got regular pain medication and analgesia. We taught her how to do some basic exercises with her lower limbs, elevation, and of course diet control because she was non-insulin dependent diabetic. Monitoring the blood sugars is really important. And then of course taking regular wound cultures for MRSA or for VRE or to see what kind of bacteria were growing in the wound. And we all know that Staph aureus lives on our skin all of the time. So when the nurses are culturing on the ward, I always ask them to use the swab to the deep innermost part of the wound and not the peri-wound skin, because you'll only grow Staph aureus there. And it's important that we talk to the microbiology team to find out what is the best antibiotic should they need, or is it suitable just to use a topical antimicrobial. So we would have maybe soaked these limbs, washed them, as Zena said, good cleanliness, good exercise, good oxygen control and good bacterial control with the honey dressings. And she did go on to heal, but she did need some superficial compression. But the problem, as I said, these days, these wounds are not as simple as we know. And the evidence will tell us that venous ulcers will only heal by compression. But very often on a day-to-day basis, we're challenged with people with peripheral artery disease and venous disease. And when they have mixed vessel disease, it's very, very difficult for us to put them into full compression therapy. And when we talk about compression therapy, we're talking about multi-layer bandages, whereby we squeeze the limb so that the vessel or the valve in the vein is actually coming together so that the venous blood can go back to the heart. If not, it just leaks out the wound all the time. But sometimes, because they have arterial disease, we don't always have that option. So therefore, we're trying to stop a leaky tap without actually fixing the faucet. Silver is very, very useful as well. We use it on a daily basis. It does have an antimicrobial effect. It only works in ionic form, so it's important that we get the dressing with the right form of silver. We have newer dressings now with slow release silver in them. So it means that if we do need to put somebody into compression, we can put a slow release silver on underneath the compression, and then the public health nurse doesn't have to do the dressing every day. She can do it twice a week or maybe 3 times a week, depending on the level of exudation. We know that, according to the literature, we have good global influence on wound healing with silver dressings, such as this one here and this one here. And they come in various different sizes. This one will be for a cavity wound. This one will be for maybe a topical wound. And then these would have more absorbent properties, and some of them actually have carbon in them as well for deodorizing. So we have lots of options available to us. Now, if we had smelly telly here, you wouldn't be able to smell this wound. It's actually really, really awful. And this poor young girl was a venous drug abuser. She came to the clinic and she had repeated infections. We treated her with silver numerous times, but unfortunately she wasn't really very compliant and she didn't always come back for the dressing change. So, I mean, it's very hard to force your patients to come back, even though you say to them it's really important that you try and attend as much as possible, that you look after your diet and exercise. But unfortunately, they don't always come back. But if we had smelly telly, this is very, very typical of a Pseudomonas aeruginosa infection, which is typically related to venous ulcer disease and wet wounds. So when you take off the dressing, you can see this greenish discharge on the dressing, and even without swabbing it, you can nearly diagnose Pseudomonas. But the case I want to talk to you about is a guy who's very close to my heart and is still around. He's a multiple sclerosis patient who attends Beaumont Hospital on a regular basis. In fact, 10 years ago, he had really, really bad pressure ulcers, and we managed to heal them over a long period of time. And he had a picture of, you know, the tennis player that used to, you know, have the skirt hitched up, and he used to say, I'm going to have a bottom like that when I leave here, Julie. And indeed, he did heal, and it was fantastic. And he's come back recently then with this problem of a slow healing surgical wound. He had a baclofen pump inserted under the abdomen, just in under the skin, to control spasms and pain for his multiple sclerosis. Now, unfortunately, we cultured Pseudomonas aeruginosa in that infection. He was treated with multiple antibiotics, and we tried various different dressings, and then the pain clinic asked me to come down, and this is what I saw in his wound. Now, it's not very obvious Pseudomonas infection, but we were able to culture it, and the wound is starting to break down even here. So the pain specialist, Dr. Keaveney, was getting really worried that the pump would have to be replaced and there was a risk of infection. And he wasn't really that keen to take him back to surgery, so he said, Julie, can you do anything with it? So I said, well, we'll try a silver load dressing to reduce the bacteria, to promote healing, to absorb exudate, and to protect the peri-wound. As I said, we want that wound to close in very, very slowly and heal over so that the pump wouldn't be stretching it and come out to the surface. So we put on the topical antimicrobial, and I saw him on a weekly basis in the outpatient department. And it was important that we cleansed the wound on a regular basis. We used a silver dressing with an absorbent property as well. We wanted to reduce that egg sex fluid, to protect the peri-wound from breaking down further, and also to educate him to keep it clean and dry in between dressing changes. Now you can see here, I'm not sure whether I have a fully healed one, but you can see as the time went on, this lovely epithelialization that started to happen in the wound gently closing in, and this didn't further break down, and he wasn't suitable for grafting because he couldn't go for surgery. So it's not always an option for them to have surgery. So larvae then, as Zena said, they kill bacteria in their gut, and they debride very efficiently, removing the dead tissue. One treatment takes about 4 days. We actually get them over from Bridgend in the UK. They're cultured in a lab or bred in a lab. They're very safe to use. And this picture here shows you the little tea bag with these little foam pellets in it. And the larvae are alive in there. And what's nice about this is it's aesthetically pleasing for the patient, because when they go on topically, they're not afraid that they're going to crawl anywhere or disturb the patient beside them or their partner or whatever. So the nice thing about the maggots is some people in their mind's eye as well have a vision of them actually biting their wound, and that doesn't happen at all. It's actually the saliva that secrete the proteolytic enzymes. And the beauty of that is not only are they cleansing and debriding and ingesting the bacteria in their gut, and as Zena said, because of the re-emergence of multi-resistant organisms and the overuse of antibiotics, we don't want to subject them to antibiotics unless they really need them. And the nice thing about the larvae is they actually can kill MRSA and VRE and such like in their gut. So they can eradicate the wound completely of infection, and there is research to support this. And then sometimes if we can do that, the patient is ready for a graft to be done by plastic surgeons. And that's really nice because you know that your wound is free of bacteria. The proteolytic enzymes have been shown to have properties that stimulate wound healing, so they can stimulate fibroblast activity. And they also secrete ammonium and calcium carbonate, which can help in the bacteria digestion. So here you can see a lady had a traumatic wound here, hematoma on the lower calf. She was on warfarin, so it was kind of difficult to decide whether debridement or larvae would be an option. But in consultation with the plastic surgeons, they were able to loosen some of this, we were able to soften it up and use the larvae over a period of 4 to 5 days, and it did debride nicely. Before we had the tea bag version, I used to use the live version. Here we have the guys going on. We used to have to protect the peri-wound with some Sudocrem and a net bag and some sleek. But as I said, I tend to use the tea bag version now, because then they can't escape. And here they are going on and ingesting the dead tissue. This was the before and the after. And you can see the beautiful tendon there being preserved. Now, it's really hard for a surgeon to operate and not disturb tendons, as you well know. So the beauty of the micro surgeons is they will only ingest the dead tissue, as Zena said, and then leave this wound for you ready for grafting. So this poor unfortunate guy was an amputee, a diabetic patient, and the vascular surgeons were having a problem healing his wound. As you can see here, it's slightly inflamed and cellulitic, and there's still a suture here with some dead tissue. So I suggested that we try larvae therapy on this patient. He was a 79-year-old man. He has a history of diabetes. He had chronic end-stage renal failure, peripheral vascular disease, a chest infection. So you can see these types of patients aren't really suitable to go to theatre. Sometimes the risk of taking them to theatre to debride a wound is far greater. I mean, they might make it out of the surgery. So to use alternative methods is a really, really good opportunity. I have treated loads of patients with larvae and nobody has ever refused. And I think it's really important that you sit down and explain to the patient what do they want, what's the most important thing for them. It's their choice, it's their wound at the end of the day, and nobody has ever refused larvae therapy. And in fact, we've had some really good results with it. He was infected with MRSA, he was treated with numerous antibiotics and vancomycin, and you know that those antibiotics can be really harsh on their systems, causing diarrhea and lots of side effects that they don't really like. And of course his rehabilitation is slow, which is really bad for us as a hospital, because we're supposed to be moving these patients on out to the community and getting them well and back into the society. So here are the little larvae going on. This is what the bags look like, and we would have placed a few different bags around the place. And just put a wet gauze over it to keep them hydrated. They like to be in the dark and they like to be hydrated. So we would check them on a daily basis just for activity, and then if we felt one area was debrided enough, we would move them to another area and then get them to debride there. And we keep an eye on them on a day-to-day basis, and after about 4 days you need to take them off and then either reapply a new batch, or else you need to try a different treatment. Because I used to think that, the longer we put them on, the more work they would do. But unfortunately, no, that's not the way it works. They actually develop over a period of 4 to 5 days. They grow and they do increase in size. And the nurses actually hate them more than the patients, I have to say. But I always make sure that they're disposed of, double bagged, yellow incinerated bin. Thanks very much, guys. You've done your job. And we move on to the next stage. So, it's very important that we hydrate these wounds to remove the dead tissue. We want to reduce the bacterial load, stimulate wound healing, and of course reduce the pain for the patient, because nobody should be in pain in this day and age, I don't think. So after one session, I think this is what the wound looked like. And it is really important that we explain the therapy and seek consent, because patients have dreams about, various ideas and weird ideas about maggots, but they're actually really, really cool. So you cleanse and stimulate the wound by the exudate production. A moist wound dressing therapy, as I said, you need to have them backed up with a moist wound dressing, because if they dry out, they will die. And of course, you can't put them on a heel if they're going to be walking out to the bathroom, they'll just squish them all and they'll die. So you need to liquefy the necrotic tissue, break it down for ingestion. Analgesia can be required for them. Some of them can actually, maybe not so much the diabetic patients because they don't have much feeling in their lower limbs, but some patients might be aware of them there, and maybe analgesia would be required. And as I said, no pressure on the surface is really important. And that's why sometimes when we use them on pressure ulcers, I think they're really cool, because the nurses are determined to keep the patient off so that they don't actually have any pressure. And of course, we do protect the peri-wound with Sudocrem, because some of the exudate can be harmful to the peri-wound. And he did go on to heal and did rehabilitate, so it's a happy ending. So just like to say very briefly then, to accomplish great things, we must not only act, but we must also dream. And we do that on a regular basis. Not only plan, but we must also believe. And I would always say that no matter how big or how small the problem is for a patient to be able to sit down and listen to them and what's most important about their wound really, really does benefit them at the end of the day. And as Zena said, stress levels play a huge factor in wound healing. So it is important that we get the whole picture and a good history and examination before we actually deliver our care. So these are only just some examples of the wounds that I was asked to present. We also would use lots of other therapies. There is some literature around hyperbaric oxygen therapy, which is an adjunct to wound healing. We would use lots of various different antiseptics as well. We would use lots of topical negative pressure, which is a vacuum system. And there are lots of different options for people out there with wounds. So as Zena said, it shouldn't be something that we just accept and move on with being elderly. There are solutions for everybody. Thanks very much.
One of the really important things is that you understand what the cause of the wound is so that you're able to choose the most appropriate treatment, and to remember the importance of whole body nutrition so that you have sufficient energy in your body to be able to repair the lost tissue.
I think one of the key things is to always involve the multidisciplinary team and seek medical advice. And I think it's really important that we're all singing off the same hymn sheet, that we have one important goal,